Muy buenas noches a todos. Como les estaba contando, hoy día continuamos nuestro ciclo de reuniones con LASPGHAN y ESPGHAN y nuestro invitado de hoy día, el doctor P Bontems, destacado gastroenterólogo, jefe del Departamento de Gastroenterología Pediátrica del Hospital de Niños de la Universidad Libre de Bruselas y del Hospital Pediátrico Reina Fabiola. El doctor Bonte no solo es experto en Helicobacter, sino también tiene múltiples publicaciones en área de enfermedad péptica, de enfermedad de Crohn, de endoscopía y de ileostomías. He tenido el placer de trabajar con él últimamente, ya que estamos revisando la guía de Helicobacter de LASPGHAN y ESPGHAN, así que es un gran placer contar con él. Vamos a escuchar su conferencia y luego, por supuesto, tendremos espacio para discutir, preguntas, respuestas. So Patrick, thank you very much for coming today. It's midnight in Belgium. We appreciate, we know that you have a lot of work over there, so we are very grateful. So Carlos, vamos con la conferencia.
I'm very happy that I have the opportunity to present to you the topic of to treat or not to treat Helicobacter pylori infection in childhood, the risks and the benefits of eradication treatment. This was presented in ESPGHAN just a few weeks ago in the special interest group, and when I presented it to the whole group, I started with this question, which I will present to you. Unfortunately, we cannot discuss it, but I will read the question and then we continue. What happens when during an upper endoscopy performed due to abdominal pain and suspected celiac disease in a 5-year-old child, we find H. pylori nodular gastritis? Should the child receive eradication treatment or not? So there are 4 options. Yes, treatment should be recommended without delay. No, there is no indication to recommend treatment. 3, treatment may be considered following careful discussion with the family. And 4, treatment should be withheld until the child is 18 years old. Well, the answer to this question that most people give, which is the correct one, is number 3. And the big question is, what should we discuss with the family? Of course, we need to discuss the potential risks of developing complications of Helicobacter pylori infection later in life versus the potential risks of treatment in childhood. And that is really the topic of our talk today. So we all know that Helicobacter pylori remains a major health problem worldwide, causing considerable morbidity and mortality due to peptic ulcer disease and gastric cancer. However, peptic ulcer disease and gastric cancer occur mainly in adults. The optimal clinical management and treatment still remains unsettled, and there are evolving changes in microbial resistant patterns. And despite decades of research and clinical practice, major challenges still remain. The quest for the most effective and safe and simple therapy remains a major issue for clinicians. And the difference between children and adults is major concerning Helicobacter, since children are not just small adults. And guidelines are very, very different in all aspects of H. pylori infections. I will mention very shortly, since most of you must know, that H. pylori infection is acquired early in childhood, usually before the age of 10 years old. And This is true in high and low prevalence countries. Infection usually persists for life unless treated. Transient infection may occur in infants, but it's rare. Reinfection after treatment in adults is uncommon in both high and low prevalence regions. Reinfection sometimes is confused with what is called recrudescence, when the infection is suppressed transiently. So people think the infection has disappeared, but actually the infection is just suppressed, and then when we test again, it reappears. The biggest differences is the consequences in H. pylori infection between children and adults. The upper panel, the upper part, is the clinical outcome of HP infection in adults, the lower part in children. Most infections in adults are asymptomatic, above 80%. In children, again, 95% of infections are asymptomatic. But if we do an endoscopy, we will see a pattern which is called nodular gastritis, which has lymphoid follicles in the submucosa, and that's what we see macroscopically. Chronic atrophic gastritis and intestinal metaplasia are not rare in adults. They may appear in up to 20% of adults, lifetime risk. In children, these consequences are extremely rare. Peptic ulcers may appear in children, but the risk in children is low. It's less than 5%. In adults, it may reach a lifetime risk of 20%. And what we are all worried about is the malignant complications, gastric cancer, and mouth lymphoma, which are extremely, extremely rare in children. And in certain areas of the world, they may reach an incidence of 1 to 2%. So eradication treatment in children, there are absolute indications and there are many treatment dilemmas. The absolute indication for treatment in children is when a child is found to have duodenal or gastric ulcers. We also treat children with erosions since we don't want them to develop ulcers. And we treat them if they have or do not have complications. But these, especially the peptic complications, again, are relatively rare in children. Very rare in children versus adult. Gastric mucosa-associated lymphoid tissue lymphoma, the mouth lymphoma, again, as I mentioned, is very rare. And patients who have first-degree relatives with cancer, we do treat it. Their children, and in children with iron deficiency anemia who are unresponsive to iron supplementation, we do consider treatment. It's not an absolute indication, but we do consider treatment. In children who have only nodular gastritis, should we treat? Yes or no? We will talk about this. In children who Helicobacter is an incidental finding, like the child I just described. He was investigated for celiac disease, but we found Helicobacter. Should we treat or not? And there are other dilemmas in children with ITP and growth failure, but we won't go into that right now. So the benefits of treatment are obvious: to prevent gastric and complications such as peptic ulcer disease, mouth lymphoma, intestinal metaplasia, and gastric cancer. But these complications usually appear in adults, so maybe we should treat much later. To prevent associated non-gastric complications, there's no proof that if we treat, we will prevent. And sometimes when parents discover that the child has HP, they get very anxious. I want this to disappear. I don't want my child to have an infection. So these are the reasons to treat. However, treatment has many, many risks. The risks of antibiotic therapy, we will just discuss all these risks in the next few slides. The risk of treatment failure, the risks of reinfection, and the risk of loss of protection, not a risk, loss of protection of H. pylori against the immune allergic mediated disease. So we'll start talking about the risks of antibiotic therapy. There is an alarming and upsetting rise in resistance to resistance of H. pylori to antibiotics worldwide. Local surveillance networks are required to select the appropriate eradication regimes for each in each area. Our group, the working group of ESPGHAN, conducted a large survey over a few years to test the resistance in different areas of Europe, and we found that metronidazole resistance was close to 21% in primary treatment, and clarithromycin resistance was close to 25%. If the treatment had already received treatment in the past, this rose to 54% for metronidazole and 47.6% for clarithromycin. This study was published in the JPGN 2 years ago. So we know there is a high resistance and we don't have many options. Once we treat children with antibiotics that they don't need, they may have side effects, even that they need or don't need. They may have side effects. They may have IgE-mediated allergic reactions. They may have serum sickness, dermatologic reactions such as rashes, and the most common reactions that many times cause the patients to stop treatment in the middle are the GI symptoms, worsening of abdominal pain, diarrhea, and even CDT. So, and we know that if they don't receive full treatment, the risk of the chance of eradicating the Helicobacter are very low. All the other risks that are mentioned in this slide, hepatobiliary, renal, and hematologic, are rare, but we also should think about them. We know that antibiotics have a negative influence on the microbiota. Early life exposure to antibiotics, especially during the critical developmental window, has long-lasting effects. And there was a large, important Finnish study which looked at healthy preschool children from the age of 2 to 7 years old, and they showed that the impact of antibiotic, which was given in early childhood, lasted for 24 months, and it was more pronounced for macrolides than for penicillins, beta-lactams. And one of the antibiotics we use in HP eradication is clarithromycin, and this study showed that microbiota changes by macrolides were associated with increased risk for asthma and antibiotic-associated weight gain. There's another meta-analysis from different cohort studies showing that use of antibiotics in early life is associated with a risk for IBD development, especially in Crohn's disease. If we do decide to treat young children, we also have a risk of reinfection. The recurrence rate of HP is dependent on the prevalence of HP in the country or area people live in. A systemic review and meta-analysis showed that in areas where there was the highest recurrence rate, it reached almost 11%, while in areas with a low recurrence rate, it reached 1.6%. And in young children, there's a relatively high prevalence of reinfection. So that is another reason to consider, do we want to treat these very young children if we don't have an absolute indication? And the last topic I'm going to talk about is that treating HP may cause a loss of protection against immune and allergic mediated disease. So it's a big question. Does Helicobacter really protect against immune and allergic mediated disease? Some believe, before I say some believe, the latest Maastricht consensus, which was published recently in GATT, Statement 15 says that HP has been positively and negatively associated with some extra gastroduodenal disorders. However, the causality is not definitive. And some people believe that it is only related to the living conditions and is a biomarker of a poor household and poor hygiene, and not really causes an inverse association. But there are studies showing there is an inverse association, and I will go over some of these studies. The biggest study was done in a cohort of Ethiopian children. Over 800 children were followed from birth using questionnaires, blood tests, fecal samples, and they were studied at age of 3, 5, and 6.5 years. And it was shown in the study that H. pylori infection at any age, up to the age of 6.5 years old, was associated with a lower prevalence of both atopy and any allergic condition. And there was a large systemic review and meta-analysis on the relationship of H. pylori and atopic disease. And they also concluded there is some evidence for an inverse association. So again, when we think of treating very young children without an absolute indication, we may be increasing their risk for atopic and allergic disease. Now we will talk a bit of the inverse association with the three most important current GI diseases. The first one is celiac disease. There was a cross-sectional study that was recently published from Turkey showing that the frequency of H. pylori infection was significantly lower in children with celiac disease compared to the controls. Another study from India on a smaller cohort showed that 11.4% of participants with celiac had H. pylori gastritis versus 50% in patients without celiac disease, again showing an inverse association. And there are numerous more studies showing this association. So again, does Helicobacter protect against celiac? Maybe yes, maybe no. We do not have a definite answer, but it's definitely something we need to consider. I mentioned before an inverse association of HP and IBD. There was a meta-analysis involving over 2,000 cases of Crohn's disease patients and over 3,400 controls. They demonstrated that the rate of HP infection in Crohn's disease was 30% versus 42, almost 43% in the controls, with a negative odds ratio, again, a negative correlation. Another meta-analysis, much larger one, on 58 studies, over 13,000 patients with IBD and 500,000 controls, again showed that the prevalence of HP was lower, 22.7 versus 36.3 in IBD versus control. So the significant negative association was observed in IBD. And a recent study aiming to investigate whether environmental and dietary factors are a risk for IBD in Eastern and Western populations shows that HP was a protective factor worldwide for IBD. So again, maybe treating at a young age may increase the risk of IBD. And the last gastrointestinal disease is eosinophilic esophagitis. Again, a recent systemic review and meta-analysis comparative studies showed a negative association with a significant reduced odds for EOE in HP positive patients. The new guidelines are not out yet, but they again address the question, should HP treatment be given to children whom HP is an incidental finding during endoscopy? We did not make any changes from the LASPGHAN guidelines. We recommend that if H. pylori is an incidental finding during endoscopy performed for other GI diseases, treatment may be considered after discussion with the risk and benefits of treatment, as I presented in the first question. So my belief is that the risk in young children outweigh the benefits of eradication in most children. Of course, if there is peptic ulcer, if there are erosions, if there is significant indication for treatment, we must treat. If it is an incidental finding, if it is not absolutely indicated, we must weigh the risk as opposed to the benefit and make the decision and do not treat everybody as is done in adults. Thank you very much for your attention. I'm sorry I am not able to answer questions, and I hope my colleague, Patrick Bontems, will be able to answer any of your questions. Thank you.
Hello, dear colleagues, dear ladies and gentlemen. I'm very pleased to be here and to participate at your meeting and to present you Helicobacter pylori infection in children whom to treat. Here are my disclosures. Through this presentation, we will briefly go through what is a Helicobacter pylori infection, whom do we have to test, and whom do we have to treat. We all know that Helicobacter pylori is a gram-negative microaerophilic bacteria, and it was first described 40 years ago by Barry Marshall and Robin Warren, and 3 decades ago, Agency for Research for Cancer put it on the list of first-class carcinogen. We know that Helicobacter colonizes the gastric mucosa generally in childhood, and that it remains in the gastric cavity throughout the life if it is not eradicated. And it is mostly asymptomatic. We all know that Helicobacter pylori infection leads to chronic gastritis, but 10% of the infected children and infected people will develop peptic ulcer disease. 1 to 3% of the infected patients will develop gastric cancer, and less than 1% will develop mucosa-associated lymphoid tissue lymphoma. What will be the result of infection? It depends on the virulence of the strain, on the host of immune response, on environmental factors, and on time of exposure. We know that majority of Helicobacter pylori infections is acquired in childhood, usually before the age of 10. And how prevalent is Helicobacter pylori infection worldwide? Here we have the map where you can see the prevalence, and in darker colors you can see countries where the prevalence is high, and in lighter colors you can see countries where the prevalence is low. It was shown that prevalence of infection in pediatric age is high. It varies from country to country, and also it varies within the same country in different geographical regions. The recent studies showed that prevalence in the world in children is 35%. And it's highest in Southeast Asia region, and it reaches 60%, and it's lowest in Western Pacific region of 20%, and European region where it is about 30%. What also has been shown is that there is a significant difference between the prevalence of low and middle income families compared to high income families, and also that the prevalence is significantly higher in those older children. And it was also shown that pediatric Helicobacter pylori infection significantly is associated with lower economic status, if there are more siblings or children in the family, if the family members share bedroom, if there is no access to a sewage system, if there is a mother affected with the Helicobacter pylori, or if there is one sibling or more siblings affected with Helicobacter pylori, or when family drink unboiled or not treated water, and it is associated with older age of the children. Most of the infected children are without any symptoms, and if they have symptoms, clinical manifestations are not specific. there are no evidence that Helicobacter pylori infection is a cause of symptoms in the absence of peptic ulcer disease. And the large meta-analysis showed that Helicobacter pylori infection is not related to vomiting, diarrhea, flatulence, chronic functional abdominal pain, halitosis, regurgitation, constipation, or nausea. So how do we decide who to treat and who to test? We have guidelines from European and North American Pediatric Gastroenterology, Hepatology, and Nutrition Society that helps us. And what do they tell us? If we have a child with recurrent abdominal pain and without any alarm symptoms, it is most probably functional disorder. And ESPGHAN guidelines recommend against diagnostic testing for Helicobacter pylori, and if we suspect that the child has a functional abdominal pain disorder. But if we have a child with abdominal pain and alarm symptoms, and if we suspect organic cause, then we should do the upper endoscopy. And non-invasive testing for Helicobacter pylori are not indicated. The primary goal, according to the guidelines, is to try to determine the underlying cause of the symptoms and not only whether there is a Helicobacter pylori present or not. A couple of years ago, a large study was performed in Europe. It was a registry that included many patients, more than 1,000 patients infected with Helicobacter pylori, and it showed that only 5% of the infected children included in the study had ulcers, and 12% had erosions. So ESPGHAN guidelines say that testing for Helicobacter pylori should be performed if the child has gastric or duodenal peptic ulcer disease. If the Helicobacter pylori is identified, then the treatment should be administered and eradication confirmed. There are some diseases that are associated to Helicobacter pylori infections, and those are refractory iron deficiency anemia, chronic primary immune thrombocytopenia, and multilymphoma. And regarding the iron deficiency anemia, ESPGHAN guidelines recommend against diagnostic testing for Helicobacter pylori infection as the part of the initial investigation. But if we have refractory iron deficiency anemia and we have excluded all the other causes of this anemia, testing for Helicobacter pylori could be performed during the endoscopy. What about chronic primary immune thrombocytopenia? In this, as we know that treating Helicobacter pylori infection may improve the disease, the guideline says that non-invasive diagnostic testing may be considered. If we have the non-invasive test positive, we decide on the individual basis for every patient, depending on the patient's platelet count, whether to do the endoscopy or not before the eradication therapy. If we have multilymphoma, the eradication is a must. We have to treat it. What about gastric cancer? The risk of Helicobacter pylori associated cancer of multilymphoma during the childhood is extremely low in Europe and North America. And unfortunately, we have no good biomarkers to identify the small number of individuals that will develop this complication later in life. Gastric cancer is the fifth most common cancer. It's the third leading cause of cancer that's worldwide. And eradication of Helicobacter pylori infection reduces the risk of gastric cancer in infected subjects. More than 60% of new cases happen in Western Pacific regions. And here is a list of 20 countries with the highest incidence of gastric cancer. And here is the projection of how the incidence will rise in the future, and it will rise mostly in Asia, and other parts will remain mostly stable. So a couple of years ago, Type A Global Consensus was published on screening and eradication of Helicobacter pylori for gastric cancer prevention. And it says that screening and eradication of Helicobacter pylori for gastric cancer prevention is recommended in populations with a high incidence or high risk of gastric cancer. The strategy of screen and treat is most cost-effective in young adults. And screening young adults and not children or adolescents is likely to be an effective approach to prevent transmission to children and to protect those who are not infected within the family. So in conclusion, who do we test and who do we treat? If we have a child with upper GI symptoms suggestive of organic disease, and if the child has an alarm symptoms, we should do the endoscopy. We also should test and treat children with GI symptoms and who have gastric or duodenal erosions or ulcers at the endoscopy, and we should test them for Helicobacter pylori, and we should treat Helicobacter pylori infection. If we have children with primary immune thrombocytopenia or refractory iron deficiency anemia, we can consider testing for Helicobacter pylori and eradication of Helicobacter pylori infection. Who should we not test for Helicobacter pylori? We should not test children with functional abdominal pain or dyspepsia, and we should not test asymptomatic children with a family history of gastric duodenal ulcer or cancer. So test and treat approach is not indicated in pediatric patients according to our guidelines. Thank you very much for your attention.
Good evening, and thank you for a kind introduction. So after the two previous talks, now I will address the problem of the treatment and especially how to improve the outcome of the treatment. Some of the data I will present are part of a PhD thesis of my co-worker, Kaliroy Kotilia. So you already know that half of the world population is infected currently, but what is mostly interesting is that with changing of lifestyle, this infection is disappearing in many places in the world, but not everywhere. And especially the prevalence is still high in some countries, including emerging one. You have heard also previously about the natural history of Helicobacter pylori infection. I just wanted to highlight the fact that being infected is not always causing disease, but a few patients will develop duodenal ulcers, gastric ulcers, or gastric cancer. And these are the main issues, medical issues we want to prevent. So you know that before the stomach was considered like a desert, meaning it looks like nothing is living in this desert. And then in 1983, two workers, Barry Marshall and Warren, discovered that Helicobacter pylori can adapt and live in this terrible living condition that is the stomach. And that was Helicobacter pylori infection, but with Helicobacter pylori. But now we know that a lot of other species also live in the stomach, and we call it a gastric microbiome. Not everything is known about this microbiome, but we just know that the main composition is Helicobacter pylori when it's present. And when it's absent, of course, there are still some other bacteria that are living there. And we don't know if it can cause lesions or eventually also be responsible for malignancies. A little bit of pathophysiology. I know that usually doctors don't like physiopathology, but I think it's somewhere interesting to come back to these very basic knowledge now. So when you take an explant from the intestine, for example, but it's true with the stomach also, and you put it in a culture, then you can see that the architecture, finally, the histology, the architecture of the mucosa is completely normal. But if you stimulate the immunity there with light finally stimulation, then you can see that the aspects looks like a celiac disease. And if you provoke a strong stimulation of the T cells, then you have ulcers that appears. So it's not only the bacteria itself, but it's also the immunity that is causing lesions in infection. And there is something completely different between adults and children. That was nicely illustrated by Paul Harris a few years ago. In fact, I'm very jealous with him because I was working on T-cell response about 10 years before. And I wanted to look for these regulatory T cells that were discovered at the end of the 90s. But my PhD promoters didn't want me to look at this. And he said, no, it's not true. It's not existing. And then Paul Harris comes later, and then he showed that you can see that in the stomach of adults infected by Helicobacter pylori, there are only a few of these orange cells that corresponds to T cells expressing CD25 and FOXP3, meaning probably T regulatory cells. But in the stomach of infected children, there is a lot of T cell, of regulatory T cell. Also, you can see that in infected children, there is a induction of the secretion of TGF-beta and of IL-10, much more than in infected adults. And on the opposite, infected adults have a strong interferon gamma response, and in children only a few interferon gamma is produced. So it means that certainly the bacteria is the same, and the toxins produced by the bacteria are the same, but the lesions is probably less important because of different immunity that is expressed at that moment. And now we know that in children compared to adults, you have a lesser activation of NF-kappa B. You have less strong recruitment of polymorphonuclear cells, and especially neutrophils. You have, as I saw before, less strong induction of Th1 cells and Th17 cells. We also know that the production of antibody is lower, but that T regulatory cells are higher. So it's complete different immune response. So why is it important? So that especially because maybe it's not always necessary to treat this infection during childhood, but it's sure that if you want to live long without any other disease, then one day, if you become contaminated, it will be interesting to be eradicated. But it's not always during childhood that you need to be treated, maybe. So what are the good indication to be treated? Abdominal pain, certainly not. Test and treat certainly is not recommended, not in short stature, also not in iron deficiency anemia, but only in anemia that is refractory to oral iron supplementation. Maybe in chronic immune thrombocytopenic purpura, but this is not, it's really debate for the moment. In case of incidental findings, when you perform an endoscopy, you have to discuss with the patients and the parents. And of course, if you find ulcers or erosions, then you have a strong indication to treat Helicobacter pylori. This is certainly true in regions where gastric cancer is not so prevalent, but in some other countries like Japan, Korea, for example, Asia, certainly, and some other places around the world, maybe treating will be to prevent gastric cancer, will overweight the risk of treatment finally. When you want to offer a treatment to children, especially without ulcer disease, it's really important to explain to the family that there is probably no link between the symptoms and the fact that the child is infected by Helicobacter pylori. So treatment is not always necessary and is certainly not mandatory. But information is something you need to give to the family, for sure. And the discussion also must include the potential risk of treating the child, meaning the risk of the treatment, failure, adverse effects of antibiotics, effects on the gut microbiome, and the positive effect of the treatment may be a prevention of ulcers and cancer, of course. But while we have some data now in adults showing that having a massive screening and treatment decrease the prevalence of gastric cancer, we are not sure that if we are doing this in childhood, it will indeed have the same preventive effects because the time before the cancer appears will be very long. So about treatment, in beginning of this century, we in Europe perform a registry and to see what were the results of the treatment that we were giving, and you see that only 60 or 67% of the children that were treated at that time were properly eradicated. So that was for us a very low level of efficiency, and we really wanted to improve these results. For a long time, we used triple therapy with PPI, amoxicillin, and metronidazole or clarithromycin. At that time, the treatment was not tailored to the antimicrobial susceptibility tests, except in Brussels. So there was a possibility to improve, but how to improve? Certainly, first is to give an optimal treatment regimen. The treatment didn't change a lot since the last 20 years, just we give it for a longer time, since we also now in Europe treat for 14 days. And we give triple therapy that includes clarithromycin or metronidazole. But recently, with the last registry that we performed, you see that we reached a goal of 90% of success. It's true in first treatment, so in naive patients, but it's not the case after failure of therapy. So because a second line treatment is only efficient in 60%. So it's really important to have the right treatment from the start and try to have the highest eradication rate possible from the first trial. So the treatment that are recommended now is to use triple therapy with clarithromycin if you are sure that the bacteria is susceptible to clarithromycin. In case of resistance to clarithromycin, then we will use metronidazole instead. Certainly if the bacteria is susceptible to metronidazole, but also in case of double resistance, we will treat also with metronidazole. Bismuth-based treatment, bismuth quadruple treatment can be proposed also, and I will give you some data about it a bit later. When you don't have the access to microbial susceptibility, then we recommend to use PPI, amoxicillin, metronidazole, or bismuth quadruple therapy. So we clearly, in the last guidelines, recommend to tailor the treatment to the antimicrobial sensitivity, as I showed you before. Culture-based methods are quite demanding and difficult, but now we have molecular technique, especially for clarithromycin. And since COVID time, performing PCR is possible everywhere in the world. I didn't say that it's cheap, but it's certainly available. Another important aspect is that it has been shown that patients who fail the treatment usually have an intragastric pH lower than those who had success in their treatment. And this is true with the intragastric pH, the value, and also the percentage of time below a pH of 4 that is higher in case of failure than in case of success. So a very good control of acid secretion is important. Another aspect is that usually pediatricians prescribe antibiotics using milligram per kilo body weight. And doing that, the second registry that have been performed show that sometimes the dosage that is given to the patients is too low. And this is especially true, you see, for amoxicillin, since in 2013, if the median dosage was 46 milligram per kilo body weight, that means that half of the children receive less than this amount. So a lot of children were not receiving at least 50 milligram per kilo body weight. So we suggested to stop using this calculation, because usually the dosage was not sufficient, and to use instead some tables with fixed dose depending on body weight range. And this is what have been proposed in the guidelines that was published before. Another aspect that is important, besides these are data that will be soon published, and you see that reviewing the data from Brussels, we have been able to show that if we increase the dosage of PPI, we have better eradication. But also another aspect that is important is that you have a higher rate of success if you give the amoxicillin in 3 divided dose. So it seems difficult to give 3 times per day medication, but if you consider giving the 3rd dose, in fact, eventually when the child is coming back from school, then it's finally feasible. And if you explain it correctly to the family, it's still possible to do it. And it really changed the eradication rate, because you see we move from 85 to 96%. So you gain 10% of success using amoxicillin in 3 divided dose. And if you increase PPI, you also gain 10% of success. And these are the fixed dose that we are using now in Brussels. You have it here for esomeprazole. Usually we use esomeprazole. You have it for amoxicillin, 3 divided dose, metronidazole, or clarithromycin. And we have a body weight range from 20 to 24, 25 to 34, 35 to 49 and above 50 kilo. Here you also have the dosage of bismuth subcitrate that we have been using in our recent trial that was published in 2021. So another very important thing is to explain to the family the importance of the adherence to the treatment. Of course, if they don't take the drugs, it's not efficient, but also we have been able to show that if the patients take at least 90% of the medication that were prescribed, then we have 90% of eradication. But if you have below 90% of concordance between the treatment prescribed and received, then the eradication rates really decrease dramatically. And there is a link with the adverse events. Of course, if the child is experiencing some adverse events, complaints, diarrhea, or something like this, he may be willing to stop the treatment. So before prescribing treatment, I always explain, okay, at school with 50%, you pass. It's a success. But for me, you need more than 90%. And using this kind of element of language, finally, you can persuade the family to stick to what was prescribed before. So what about bismuth? Bismuth is a very old treatment, but that comes back now on the front line in papers. So it was used before, usually in triple therapy with 2 antibiotics, and the results were already very nice. But more recent data have been done using PPI, amoxicillin, and not tetracycline in children, metronidazole, and bismuth subcitrate. So these are series published in China. The first one gives only 84% of eradication, and we wanted to have 90%. But the second publication of the same team had a better eradication of 90%. It was published in 2020. And these are our results, exactly almost the same treatment. So quadruple bismuth with bismuth for 10 days. It's a monocentric prospective trial. We only treat children when they weigh at least 20 kilo, and we usually only treat children when they are able to swallow tablets, because syrup maybe is not as efficient, and especially it's a lot of syrup to swallow, and you're never sure if the child will be able to do that. And with this treatment, we had 97% of eradication. It's working also in case of metronidazole resistance, and it's performing also as a second line treatment and a little bit less as a third line. But more data, of course, are needed, and we should have a larger series. We stopped our trial because due to COVID, of course, recruitment was not possible anymore. So just a reminder also that we recommend that at least 4 weeks after the end of the treatment and after stopping PPI for at least 2 weeks, you have to control the success of your treatment, and you can use urea breath test or monoclonal stool antigen test. As a conclusion, there are usually rows for improvement of eradication success of Helicobacter pylori. First is certainly to select adequate indication, because it needs a lot of time to explain to the family and to be sure that they will be able to follow what was recommended for them. So take the time to be sure that the family understands correctly the need for very high compliance to the treatment. And for that, you really need to have in-depth discussion about the expected effects and especially the risk, meaning the side effects. Duration should be 10 days. Probably if we do again the trial with bismuth quadruple, we will treat for 14 days instead of 10. Don't use macrolides if you don't have any information about susceptibility. Use amoxicillin in 3 divided dose and use a higher dosage of PPI to have the best possible results of the treatment you will prescribe. And this is the end of my presentation, and I will be very happy to take any questions.
Ok, muchas gracias Patrick por la excelente conferencia. Gracias también por invitar a colegas tuyos de Europa. I'm speaking in Spanish because we have some questions. Most people here speak Spanish, but we have some question in the chat. So, Patrick, what do you think about the question from Jorge Amil from Portugal? He's asking you about the high prevalence of HP and the low prevalence of gastric cancer in Israel. So he believed that it goes against the argument that treatment may prevent future gastric cancer. So what do you think about it?
So thank you for giving me the floor, Paul, and hello, George. Long time we didn't talk together. Well, hello to Portugal. It's the night there also. So indeed, in Africa mostly, there is an enigma, meaning that the infection rate is very high and cancer is low. But it's mostly true for Africa and this region of the world, and certainly not in Asia, not in Eastern Europe, for example. So there are some data now showing, but it's still indeed mostly in Asia. And we are expecting results also from Baltic region, from Slovenia. That shows that eradication is preventing gastric cancer, but they are treating adults, they are not treating children systematically. And there is this beautiful publication about an island just in front of Taiwan, I think. And they showed that they have been able, with massive screening, to decrease the eradication rates and to keep a lower rate of infection. And at the same time, it prevent gastric cancer. But it's not true in Israel, indeed. So it's not that there should not be, it should not be a reason not to treat in Israel also or in Africa, but it's also an opportunity, this local situation, to understand what is different there and to have better knowledge about cancer development. For sure, it's for me not reasonable to accept parents' anxiety as indication for treatment. Should stick only to science.
Ok, thank you, Patrick. Mientras tanto, invito a quienes quieran hacer preguntas, las pueden escribir a través del chat en español o en inglés, y Carlos Timosi la va trasladando al chat para yo transmitírsela a Patrick, o si es que Carlos nos permite, se puede hacer también a tiempo real. Meanwhile, I want to ask you, Patrick, here in Latin America, people love probiotics. People use probiotics for everything. So I wanted to know your personal thoughts about using probiotics as part of the therapy for HP eradication.
Yeah, so there are some data mostly or not always very well controlled, suggesting that if you give probiotics, you will have a higher rate of eradication. And but still, these studies are not able always to prove that they reach 90%. So my main message is giving more drugs means a more complicated treatment and more complicated for the family to follow it. So more is not best. And you can reach 90% or 97%, like in our last study, without using probiotic. And probiotic alone will never treat Helicobacter pylori.
Thank you. Fully agree with you. Moving to the issue of resistance, even though we already have a lot of PCR machines in South America, studies for H. pylori antibiotic susceptibility is not really something that is used in a usual fashion here in Latin America. So if we have to decide a standard triplet therapy, what would you suggest for us? Metronidazole or clarithromycin with the amoxicillin and the PPIs? Which would be your first choice for us here in Latin America?
The problem with macrolides is that if the bacteria have these mutations that confers resistance, the minimal inhibitory concentration will be so high that you will have no in vivo effect. On the contrary, with the metronidazole, it's difficult to have a reliable method to assess the susceptibility. And if you give a higher dosage, you can finally have a good success in vivo, while it's not working in vitro because the MIC is increasing. So definitely don't give macrolides if you don't test for susceptibility, and give metronidazole instead.
Good. Thank you, Patrick. Carlos, yo tengo más preguntas, pero quiero saber si tú tienes alguna pregunta en el chat. Okay. It look like I have another question, maybe the final one. Is regarding the issue of gastric cancer. This is Latin America. We are plenty of gastric cancer adult patients. If you ask in the families, there's always someone who has had gastric cancer. So we have discussed this before in the panel, but what do you think about the issue to treat first-degree relatives, I mean children, with parents or second-degree grandparents with gastric cancer, grandparents who already are dead or who already are under chemotherapy or who underwent surgery. So this is a big issue for the family. It's hard for them to wait many years to treat the child. What do you think in this specific Latin American setting?
It's probably not only true for South America, but the previous guidelines suggested that first-degree relatives should be eradicated if they are infected. Second degree, and indeed, then you start treating everyone, and mostly not all centers have 90% of efficacy, so you will treat a lot. You will not, with this, have always a very good results. You will increase a lot the anxiety within the family. And we don't have any proof that treating these children in childhood, during childhood, will have the good effects. There is also a higher risk, like Michal showed you before, to have a reinfection when you are living in a country with a high prevalence of infection. And probably reinfection may be higher when you're a child and probably have closer contact with your relative. So I don't have any reason now or data suggesting that these children should be treated before reaching 18 years of age, having then their own choice. They can give their own ID and have their own voice to decide to take a treatment or not. Because having a cancer before 18 is very rare, very, very rare. And then usually you have another disease or another genetic defect. So only first degree relatives, and you probably have time to do it before any metaplasia or dysplasia is appearing in the stomach if you wait until 18 years of age.
Thank you, Patrick. Carlos, no sé si tenemos alguna pregunta por tu lado antes de cerrar. Ok, gracias a todos los asistentes. Esta conferencia va a quedar grabada para que la distribuyan o le comenten a sus colegas y estudiantes. Patrick, we don't have any more questions today. This conference is going to be available in the LASPGHAN website, so I'm sure that many people, students and colleagues are going to be able to look at the conference. So I want to thank you very much for your effort and to share with us your experience and the European experience. Thank you. I hope that we will have another opportunity to share this experience and result. Thank you very much, Patrick, for coming with us. And please.
If I can just say the final words, don't always think about treatment, but think also about prevention.
Exactly. Thank you very much. Thank you all. And have a good night for everyone. Thank you. Bye-bye.